For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 2, Episode 56 of Surfing the NASH Tsunami. Our coverage of the final day of the 2021 AASLD conference starts now.
This week on Surfing the NASH Tsunami.
We have some amazing data coming out now, linking NITs to outcome measures, some elegant data. And I just feel like we're at this precipice, this cusp, where something's going to give. And I'm hoping it's the liver biopsy that gives.
We built a real bridge with the FDA there between patients and what the outcomes are needed for drugs to become available here. And this has been a direct way for patients and clinicians to be able to ask questions of each other. Like, so what does this mean for people with transplants? What does this mean for cirrhotic versus fibrotic?
Yeah, so I think at this stage of a drug's life, they're all effective and they all have no side effects. So that's where we are right now with this one. So I'm not surprised. I think we're where we were.
Michael, is that adolescence or pre-adolescent?
This is pre-adolescence, I think. The two ways are mostly, they all work and they have no side effects.
Severe liver outcomes occurred in 2.2% of patients with low risk FIB4s, 4.2% of patients with intermediate risk FIB4s, and 20.8% of patients with a high risk FIB4. So these were patients that hadn't been ever picked up because GPs don't really engage and haven't done with FIB4. It isn't something that they talk about in primary care. But 49% had no chronic liver diagnosis beforehand. That is absolutely frightening.
Years ago, there was a pessimistic look or opinions about the NASH field with multiple trials that failed. We have drugs that can do as good as weight surgery, and these drugs are working on NASH. So we're going to get there no matter what, because we know we're going to achieve the solid outcomes.
This weekend, thousands of stakeholders from across the global hepatology community convened virtually for the Digital Liver Meeting 2021, a 4-day event with well over 100 sessions on a broad range of liver-related topics. Join hepatology researchers and key opinion leaders, Dr. Stephen Harrison, Michael Charlton, and Mazen Noureddin, Global Liver Institute Director of Global NASH Programs Jeff McIntyre, liver wellness advocate Louise Campbell, and pricing and forecasting guru Roger Green as they review some of the important posters, presentations, and general discussions taking place around the last 2 days of the Digital Liver Meeting, today on Surfing the NASH Tsunami.
So, about a half an hour ago, I finished listening to our friend and colleague Manal Abdul-Malik perform the oratorical equivalent of drinking out of a fire hose, wrapping up 4 days of fascinating presentations in one 30-minute talk. When she's with us tomorrow for the wrap-up episode, we've got to remember to ask her how she chose the order in which she presented and what she had to give her kids to get them to highlight all those abstracts to help her get them organized. Okay, let's move on. I spent a long time yesterday introducing this program, only for it to turn out to be the longest episode we've ever done in this podcast that did not have a 30-minute sponsored back end to it. So today, all I'm going to say again is that no one can cover a meeting of this complexity and scope in 2 podcast episodes or 3 or 4. So we have the same format as yesterday, 3 different key opinion leaders. Louise Campbell, who was down in chocolate and coffee a couple of minutes ago to make sure she can get to the end of the session at 1:30 in the morning, her time in one place. The charming and eloquent Jeff McIntyre, me. And over the next 90 minutes or so, we'll talk about some of the major presentations and themes of the meeting. We're actually going to go back to one paper we talked about yesterday because everyone thinks they can cover it from a different angle, and I didn't cover it that much at all. And that's what we're going to do. Basic format's pretty simple. I'm going to introduce our panelists in a minute. Between us, we'll present somewhere between 8 and 12 presentations or posters that we individually feel help tell an important story as part of this meeting. If you're in the live audience and you want to ask a question and you look at your audience screen right now, there should be a button at the end, a blue button towards the bottom of your screen that says something like ask a question. I forget exactly what it says, but it's a blue button. It has to do with a question. You click on the button. It will ask you what camera you want to use and what microphone you want to use. And then it will ask you to type out your question. And when you're done with all that, I will see it. And we'll figure out how to use it from there. So that would be fun. All right. With that, let's introduce our panelists and do the groundbreaker question at the same time. Instead of doing key opinion leaders alphabetically like we did yesterday, we're going to do them in the order of how many times they've been on the podcast. So, Stephen, welcome back.
Thank you, Rogers. Great to be here. It's great to be talking about, kind of what we went through today and really highlighting a couple of the key topics that were discussed during AASLD. I've been looking forward to this all day.
As have we, and Stephen's having some small internet issues, so if he gets a little hissy, or if you're on chat and you see that he's not on video, that's so we can do a better job of keeping him with us. And then next, order of appearance of Mazen Noureddin. Mazen, how are you this evening?
I'm doing very well. How are you?
I'm doing fine. If we have time at the end, Mazen will regale you with tales of his omakase dinner last night, but I don't think we all need to hear that immediately. And then Michael Charlton. Michael, how are you this evening?
Very good. Thank you, Roger. Thank you for having me back.
Thank you for joining us. I'm really excited about getting this cast of characters together. Jeff, you were tweeting early in the morning about doing this late at night. I was really impressed by your endurance.
The patient advocate never stops here, Roger. Thank you for having me on again.
Our pleasure. And then Louise, for those who don't know, it's 12:45 right now in London, and Louise was eating chocolate to get ready for this event. Actually, she was crunching chocolate to get ready for this event, but now she's...
I was having a Malteser. It's mainly air.
Point well taken. So with that, I'm going to go back to the groundbreaker we used last night, which I kind of liked. It's two-parter. And we'll do Brave One go first. First one is, what one word or brief phrase, not more than 3 or 4 words, describes best how you feel about this meeting? And then the second one, just so we can set it up, is going to be, what's the most powerful moment or presentation or fact that you witnessed over the course of the meeting? Brave One go first.
I'll go. So to me, the overall feeling I get from the meeting is a focus on non-invasive tests. And from listening to the chat and the Q&A, it's a little bit like an immovable object meeting an irresistible force. It's like we have the endpoint that's set in stone, almost like the biblical 10 Commandment tablets of this is how you will conduct your trial, and this is the endpoint you will hit. But in the same token, we have some amazing data coming out now, linking NITs to outcome measures, some elegant data. And I just feel like we're at this precipice, this cusp where something's going to give. And I'm hoping it's the liver biopsy that gives.
So, Stephen, because you weren't with us last night to be my conscience, I did actually go there for the first time on this podcast and call a biopsy pyrite, the pyrite standard instead of the inadequate gold standard. And I was inspired by yesterday to do that for exactly the reason you're talking about. So was there a particular moment at which that really stood out to you?
No, there really wasn't, Roger. It was just the repeated drumbeat of data and the repeated pushback by people relative to what that data means. And I, just kind of sitting back listening and not being an active participant in those discussions, you could kind of get the feel of the yin and the yang, the pull and the push. And it was just a unique perspective. I feel like it's a little bit like Maffled and Naffled. There are proponents on both sides, and everybody's bringing their best argument to the table. And I think at some point we are going to get to a tipping point on both of those topics, quite frankly. But I feel like that is getting closer and closer and closer to these NITs. And 2022 might be a very important year for kind of getting to a point where we can move beyond, like legitimately have a discussion about moving beyond the biopsy. It will likely come in cirrhotics before non-cirrhotics, but I still think it's going to happen sooner than later.
All right, go ahead. Who wants to go next?
Okay. I'll go a little bit general. I was in general impressed by the amount of the trials and the data that have been done during the pandemic, and people pushed through. People did research during this time. I still wish it was the right thing to do this meeting virtual. I still wish that I sat down with you guys and had omakase with all of you, and we had dinners, but hopefully next year in Washington, D.C. The wow moment for me has been always when you give people the awards for their accomplishments. I look up to people that they have accomplished in the field. So I don't need to talk about, the people that accomplished in hepatitis C or John Verling or the others, but also our beloved Donna that has been here in this show and this new award and patient advocacy. So I always sit there and watch, and I always, and part of like what always excites me is the history of medicine and listening to my mentor how people contributed to medicine. So that's always like a chilling moment for me. So I enjoy these moments.
That's great. Next.
I can go next. I feel a little bit as if I had one word, it would be adolescence. I feel the field is approaching adolescence. It's not mature yet, but it's maturing. And I think we're getting beyond the childlike phase of expecting histology to help us develop a drug for this condition. The non-invasive tests are emerging as probably superior. And I think earlier in the year, when the ASD had the Emerging Topics Conference, and Frank Anania said, listen, histology is just a biomarker for the endpoints we're interested in, which is survival, liver-related endpoints, HCC, transplant, et cetera. And I think once we fully internalize that, then I think we can properly mature. But right now we're in the adolescent phase where we still want some childish things. We're not ready to let them go completely. But I think we're moving in the right direction.
Okay, I'll go next because I want to respond actually kind of to what Michael said. So one of the things that struck me is, and this is closer to where Stephen was, I kind of feel the whole thing bifurcating, right? But what's interesting is I don't think, now admittedly I'm biased, but I don't think I heard an argument in the entire meeting in support of biopsy that wasn't some version of that's what we've always done and I can't trust what I don't know. At these moments I tend to talk about Premarin, which I'm not going to do right now because we've got plenty to fill today. But FDA has been known in the past to say, if you can't replicate something that's bad, you can't move past it. So I think you're right. When Frank made that comment and a couple of the other things that I think we've heard recently from the from FDA, Joe Turner reportedly at the patient-focused drug development texting out a comment to the effect that this is going to change how he looks at things. So I think we're getting to the point where the momentum is going to swing in favor of what, standing behind what Frank said, that you just reported, Michael, and getting away from, this is what we know, so therefore it's what we know. And I felt that all the way through this meeting. I kind of felt the way about the drugs also, by the way. Jeff, Louise, go ahead.
I'll jump in next. I think I was, like Stephen last night, I was talking about the non-invasive technologies. And I suppose for me today, the standout session wasn't the one that I was primarily going to cover tonight and listen to. It was done in the Parallel 29 session, the NAFLD and NASH management outcomes in the clinic, and it was the presentation by Andrew Schreiner on FIB4 index in primary care, which was a wow moment, which hopefully I might cover later if somebody else doesn't cover it. I promise now it won't do as much justice as I might have done, because it was just a wow moment. In some of the figures that he was producing, and it set off a lot of debate and questions in the room on that.
Well, so I personally would love for you to share that, even though it wasn't what you committed to, because I didn't get to see it, but I took a look at the talk, and I said, boy, that could be fascinating. Okay, Jeff, I guess you're right.
It was.
Yeah.
I wholeheartedly agree with Michael on the notion of adolescence, and I think what I'm about to I come out of it with is very analogous to that of finding the field in adolescence, because the word I had landed on when you asked was actually bridges. that I feel like, even though I can definitely be a little Pollyanna-ish with my optimism about this, what I felt like coming out of all these sessions were that there were bridges that were being built, or at least being acknowledged and recognized, between non-invasives and future treatment, certainly between lifestyle and a more clinical medical approach, or even being able to better understand the gaps in lifestyle that can be better understood. Certainly, I've got written here endpoints in the FDA, and as one of the individuals that organized that patient-focused drug development symposium, I feel like we've built a real bridge with the FDA there between patients and what the outcomes are needed for, drugs to become available here in this. And I think most importantly, too, I'm finding that there are even better, more patient participation in the meeting this year with more bridges between patients and clinicians. This has been a direct way for patients and clinicians to be able to ask questions of each other. And when you mention a powerful moment, I would refer to a session on nutrition. It was Nutrition 101 by Dr. Jennifer Lai and Jonathan Stein. Lai's out of UC San Francisco, and Jonathan's out of Penn State. I believe he's been on the program with you before. And it was amazing. People that I know and have worked with as a patient advocate, who I respect and feel like they really have their finger on the button in terms of what's going on, were very quickly coming up with just like, so what does this mean for people with transplants? What does this mean for cirrhotic versus fibrotic? And almost saying, eat this, not that. And it was just a great, exciting example of seeing, a ton of people show up to the session with a lot of interest. And I'm going to be looking forward to Nutrition 102 and hopefully a lot of education and material in this area to come.
Okay, so duly noting that we've lost Stephen again, just for anybody who's listening who wonders why Stephen might not contribute to the first comment. I know he'll get back as soon as he can. We can start in one or two places. We can either start where Jeff just ended, which is all the energy around nutrition, but I think I'd probably rather start, Michael and Mazen, if you want to talk about pegbilfermin for a minute and what you think the lessons of that were. I think let's do that, and then let's figure out how we get a little bit more towards non-invasives, which everybody noted was important. We didn't talk about a lot yesterday. Go ahead.
Mazen, do you want to start and just recap the results, or?
I'll go after you, Michael. I know I wanted to talk about it.
I know you discussed it yesterday, so I don't want to bore a tired audience at the end of a long meeting. But
I shared no numbers, though, so don't worry about it.
Okay. So it was unequivocally a disappointment in terms of efficacy. And there was a study of FGF21 analog in patients with NASH by Bristol Myers. So this is an aircraft carrier of a company. I mean, it can take a hit and keep moving. And the study was enough to cause them to abandon this asset, this type of therapy. In fact, all NASH therapies, it was so upsetting, it seems, that they've abandoned NASH as a therapeutic area. So it's worth looking at this study a little bit more closely, and I think it raises some issues that it should make us think about FGF19, FGF21 at large. And Bristol Myers studied this drug for a long time. Most of the data that we have come from these short film studies where you give it for 30 minutes and you measure your PDFF. They did it for a year plus, and what they saw was that things that when you do these short studies, it would have looked like maybe not a home run, but certainly a long ball. At the full study endpoints, it was a failure. It barely changed from placebo, and I think this should give us concern for any drug in that domain, whether it's FGF19, FGF21. And it raises the two possibilities, I think. One is anti-drug antibody for biologics in this area, and the other is tachyphylaxis for FGF21, which is the agent, the note here, at FGF19. So I think there are some critical lessons here from that study.
Mazen, you want to comment?
I totally agree with Michael. I don't like to talk after the fact, when I talked before the fact, I was a little bit surprised about their choice of the cohorts, the current cohorts, especially the cirrhotic cohort. I don't know what happened to choose the cirrhotic cohort. The F3 cohort made a lot of sense to me. If we want to summarize the study, the study had a placebo and 3 doses, and it was a biopsy outcome, and the biopsy outcome did not hit the primary endpoint. There was a signal, or there was a little bit change on the MRI PDFF, but as Michael mentioned, the primary endpoint was at week 24, and then they had data at week 48, which they had also MRI PDFF data, and you see the efficacy going down. Now, it was asked that if there was antibodies that led to that decrease in efficacy or dimming the effect, and the answer was no. So I believe that, but it was complete failure. The previous results was from the previous study. There was a signal, but I was disappointed with the results, as Michael was. So I don't know, Michael, if you go back, what would you have done differently? Would you not have continued with this, or what was the lesson to learn from the previous study to go with this one?
I think they did it right. I think they did it for an appropriate length of time. I think they highlighted that the studies that preceded it were too short, and that no one should be conducting a study with a 19 or a 21 for less than 48 weeks going forward. I think they should barely be thought to be interpretable. So I think that was the primary lesson there. I don't think that we can presume that it would have gone better at 2 years or 3 years. They clearly decided that the juice wasn't worth the squeeze to do that kind of a study. So I think the study was conducted well and for the right length of time, and I think that the informing data from their 2A was appropriate too. I think they taught everyone a lesson.
I think so too. I mean, I was just concerned about the cirrhotic group. I think it was a tough group to visit. Yet, I mean, we need treatments in this harder to treat population. So, I mean, they tried and it didn't work. And at the end of the day, that's why we do clinical trials. We want to see the drug, if it's working or not. Saying that, talking about the FGF19s and 21s, we have other products in the pipelines that are promising. I mean, the Kero data is quite promising. And Stephen, you've been presenting these data, and now there are very positive publications in cirrhotics and non-cirrhotics. So there are some powerful and potent FGFs. So Stephen keeps disappearing.
So you'll have to play the role of Stephen, Moss. But
I think FGFs is still a very important target. It's just that we got unlucky with this molecular in particular.
So I want to go back to one of Michael's comments, because it kind of came up last night from Naeem, actually. And I had an answer to it that I don't know how you guys are going to feel about, but let's check, all right? Naeem asked the same question, which is, if there was some effect at 24 weeks and no effect at 48 weeks, then was that problematic for the other FGF21s? We had an episode a while back that Mazen was on where we were talking about the idea that goes as drug classes mature, they become portfolio therapies. And that a drug that has some side effect issues maybe and has an inconvenient dosing form and costs a ton of money might not be a long-term therapy. That in essence, if it does its job in the first 3, 6, 9 months, and you can then get the patient over to semaglutide, resmetirom, lanifibranor, or pick the drug of your choice, that's a pretty mature way for this market to develop. In fact, that's a way to jump past adolescence in one flying leap, frankly. in terms of thinking about drug strategy. Therefore, I didn't hear anything or see anything in the peg-belfermin data that said anything to me other than, well, sometimes you do the right thing and the drug doesn't show up. And my point actually in the presentation was that you contrast that to aldafermin, where there was that one bad read on fibrosis in the 1 milligram group. Other than that, it all lined up. But part of the problem there was even if it lined up, it didn't appear to be as good at the FGF21s as what Akero and Bio89 are showing. It certainly wasn't going to compete with resmetirom, lanifibranor, or semaglutide. And that's before we get to the combination, before the combination GLP-GIPs and all that stuff. So it may be that in the end, it didn't have, even if it had come through on the 1 milligram, it wasn't going to have that much of a place to play anyway. And they had great oncology assets, and it made sense for them to throw it in. But that wasn't a clinical failure. You could have gotten that drug to market if you chose to. And that was kind of my point yesterday. But so, Mazen, going back to the episode that we had where we were talking about does that make sense that even if Akero starts to wear, even if efruxifermin or the Bio89 drug starts to wear out after a year and a half, if it does its job for the first point, that's kind of what we needed to do?
I don't think we should generalize that rule on others. That is, the effect is gonna wear. And I'm not expert on biologics, but we're all trained in gastroenterology. And I would like to pick maybe Michael and Stephen up top for a second. But we have seen that in biologics in IBD. Some of them, they have that wearing effect and others don't. And I really want to know what happened between week 24 and 48. I know that question was semi-answered today, but I think we need to see the data and dig deeper why that effect got medicated and not generalize it on all FGFs, that the effect is going to wear off over time. Saying that, there also like some FGFs are more potent than others. And don't forget, those are injectables. So you might introduce FGF for a short duration of time. And in general, you don't want to leave injectable for a long time, especially with GI side effects. And they can get you where you want in 6 months to 1 year, and you leave the patients another backbone therapy. And within this 6 months to 1 year, you reduce fibrosis, steatohepatitis, and you use other therapies. So in summary, I don't want to generalize this decrease in efficacy or weaning effect to other FGFs, because it's not generalizable rule. We have seen it in IBD, in other biologics. Some drugs develop antibodies, others don't. So this is phenomena we need to study and be careful before we start shooting a whole class of drugs.
So let me clarify. I didn't mean to say, and I'm hardly in a position to know enough to say, that would happen with every drug. My point was, given the idea of the cost and the injectable and all that, we had said previous podcasts, if you get a good year out of it and it does really well for the year, that there'll be other drugs to bring in behind it without even commenting on whether there's going to be a wear-off or not. I mean, my point was more, I wasn't sure that was a big deal than it was, or a big negative than it was, well, surely that's going to happen.
Absolutely. I think we have said that all along. If we can get a good year out of injectables, no matter what it is, FGFs or GLP-1s, we're good. Because in general, patients don't want to use injectable for a long time, although you can argue that these small needles nowadays, a lot of patients like it, especially if you get good effects with it, such as weight loss with GLP-1s. I mean, look at the IBD patients. They stay on their injectables for years and years, and they stay on it. So let's not narrow the effects before we see the efficacy.
Mazen, I think the IBD biologics is actually a good example, because it's not that we should generalize to every FGF21, 19, but that at least we raise the possibility. Now we're thinking of this going forward, because some biologics do tachyphylax, some do develop ADA. In fact, I can't think of a class of biologics, whether it's checkpoint inhibitors or immune modulators like anti-TNF that don't have some examples like this. So I think it's brought us a step forward, and that now we know that we should at least look for it and ask for longer studies.
I agree, which is another thing to add to our field that we have to start thinking about.
Well, as we leave adolescence, we stop thinking about dating and start thinking about long-term relationships, right, Mazen?
I mean, that what makes, I hate to say it, but it makes it fun. Like it's our job to help our patients and make research more interesting and exciting, and makes us more careful how we evaluate research.
So Stephen, I'm going to take a leap of faith and decide that you're back.
Yeah, I am back. I had to move rooms. I think there was some kind of copper firewall in that room, so it should be better now.
Well, good. So have you surmised what you missed?
Yeah, I think you're still talking about Peg-Belfermin.
Yeah, well, specifically, it kind of got past Peg-Belfermin itself, and it got to the question that Michael tossed out, and that Naeem had tossed out last night, actually, about the idea that it fell back to placebo at 48 weeks. Was that a warning sign for the other FGFs? And from there, we got to, we don't know. And my comment from some of our early episodes that if we could get a good year out of it and then get people over to drugs that were better long-term therapies.
Well, you got two options, really, right? Either you tachyphylax, you develop antidrug antibodies, and you fall back to baseline, or the drug wasn't very effective to begin with. My preference is to think that based on the phase 2 data that we saw from Bristol Myers, that the drug just wasn't that potent, didn't carry the bang for the buck that we thought it might. And quite frankly, the dose they carried forward was not the most biologically active, at least on the NITs that were assessed. It was a more favorable dosing schedule, and I think that's why it went forward. But to Mazen's point, all FGFs aren't created equal. All FXRs aren't created equal. And I think we've seen some early data suggesting that there are much more potent FGF21s in development. But to Michael's point, proof is in the pudding. Time will tell if it holds up over time. But I would just say that I think the IBD field is rather developed. These injectables have been around for quite some time. The IBD patients have carried their disease often for quite some time. They've been through the Imurons, they've been through the CellCeps, they've been through the oral modulators, and now what's left is injectables, and they see that it works and they're willing to take it. NASH patients, we're not quite there yet, right? We're looking for that first therapy. And so I think it's still, I'll hold to my I guess my dictum of how I think this is going to work. I think we use injectables for short-term induction therapy and then pivot.
I just want to make a comment, and our just to say our bar is much higher than IBD patients. IBD patients, they have pain, they're quite symptomatic, they're miserable, there's blood, and it's not the same thing. But I was just trying to bring the concept of the antibodies and all that. So our NASH patients will not tolerate or have the same mentality for injectable and biologics and antibodies like the IBD. But if you want to talk about the antibodies and all this, I just wanted to say, even in the IBD field, some drugs develop antibodies and some don't, as others from the same class.
Yeah, I think the rest of your point obtains. There's a bunch of literature that Jeff and or Louise and maybe the rest of you all know better than me, to the idea that the more symptomatic the disease, the more the patient is willing to bear up with to be in the therapy. And IBD for a chronic is about as nasty. For something you could live with forever is about as nasty, if not as nasty as it gets, but it's tough. So, all right.
I'll do just a little throwback on that slightly. Patients with hepatitis C who did interferon ribavirin therapy actually were often asymptomatic. And it was really finding the right time at the right opportunity in their lives to undergo therapy for up to a year for genotype 1s and 4s. So I think there is a skill set and there is a patient belief. And if you have an honest relationship to get people through that type of treatment, I think liver patients are stoic. They do understand what's coming and the potential. And I think a lot of people with viruses do want to close a chapter in their lives and things like that. So I think patients will tolerate in the right circumstances, even without pain or discomfort. So I think it's about the way we engage as healthcare professionals with individuals.
You know, we could stay on this the rest of the evening and not come back to anything in the meeting, because I can tell you the 3 places we might go next. So I'm going to ask somebody to step in and talk about a paper from the conference.
Let me turn it a little bit to positive and stay on the injectable, not because I want to talk about positive and injectable, some good effect. This is came from Arun Sanyal. It's an early concept trial, and that's a GLP-1 glucagon receptor dual drug, cudetotide, and this has been already tried in animal model as well as in type 2 diabetes. And the animal models showed improvements in steatosis, inflammation, and fibrosis. And the type 2 diabetes, the data published in comparison to liraglutide, and that led to the concept, because the liraglutide, that's where the lean study came from in NASH patients. And then liraglutide, there's data that Dr. Sanyal presented or showed a couple of slides nicely that the I'm going to call it the cudetotide from for comparison, it showed more body weight improvement, similar A1C improvement, more triglyceride improvement, more ALT and AST and ProC3, and that was published in the type 2 diabetes literature. And the trial was called Proxysma, and that was a randomized controlled double-blinded trial. Presented as oral presentation. I think it was in the late breaker or in one of the NAFLD orals. So the primary endpoint was safety. The number of the patients was about 74, 75. And the secondary endpoint, as we see in early concept studies, PDFF changes over 19 weeks, and he looked for absolute changes. Of course, there were many secondary endpoints. There was two doses, 300, 600, matched with placebo with each arm. Interestingly, they entered patients not just based on biopsy, but there was actually a biopsy-proven NAS more than 4 and F1 to 3 patients, and they also had PDFF cutoff of more than 10%. The A1C had to be less than 9.5%. Moving on to the results, the PDFF average ranged between 18 to 20%. And the drug overall was safe, although they recorded the side effects to be on the range of 70 to 90%. There were no withdrawals, and they did not go into details quite a bit, but I bet you those were GI side effects with nausea and vomiting, as you see with the GLP-1, especially when you combine it with glucagon. The PDFF absolute change was, they did it in comparison, in relative with the placebo, was 10%. PDFF change, and the relative change was 55% in that trial. They measured volume, liver volume, there was a decrease. They measured liver fat volume, there was a decrease as well. And all parameters that we look for regularly, such as ALT and AST. ALT decrease was by 50, AST 33. NIS4 that we know has been tested with the GenFit, and there was a study, there was a Lancet Gastro paper on it, decreased for C3, fibrosis biomarker, NAFL fibrosis score, APRI, FIB4, I mentioned, CK18 inflammatory biomarker, all decreased. Adiponectin, which is favorable biomarker, has increased. So a positive study, GLP-1s, glucagon dual receptors are continue to show favorable effects. So this drug, I'm assuming, is going to move forward in the pipeline for 2Bs and further. One interesting question that they asked Dr. Sanyal after the amount of weight loss, and it was not significant actually. I believe he said something in the range of 4 to 5%, but this is a 19-week study, and it seems that there are effects beyond weight loss. So we'll see where's that moving. So we have now plenty of GLP-1s and GLP-1 glucagon dual receptors that are in clinical trials. And as you know, those are the beneficial role of those that they also target type 2 diabetes, weight. And in the literature, many of them, they already have shown cardiovascular protective effect. So that was a positive, one of the positive therapeutic agents in this trial. So, and I wanted to present that. So
Mazen, first of all, thanks for sharing that. I maybe either you or Michael can help me. I vaguely remember maybe at NASH-TAG 2020 that some earlier work on cotadutide was presented from someone from AstraZeneca, and Altimmune presented work on theirs that actually looked a lot better on weight loss. And then there's a Hanmi drug that I think Manal talked about in one of her presentations here that also looked a lot better than cotadutide. I don't say that to bash cotadutide, and it's the one that's furthest along, but more to second kind of what you said, Mazen, which is that this is a really promising area.
You know, there was no slide on weight loss on these patients. As I mentioned, it was 19 weeks, and I think I heard it correctly. He said 4%. That was one of the questions. So I would like that to be confirmed on subsequent slides or publications. But I thought the weight reduction was minimum. I'm very sure he said they believe that the effects, they believe that there are effects beyond weight loss in these patients using that drug in particular. And they, as I said, in the type 2 diabetes literature, they compared it to Lera, and it did better than Lera overall, but they also had more weight loss effect than liraglutide. But in general, they did better in ALT and AST and PRO-C3 compared to liraglutide. So I will give them benefit of doubt and see how they're going to do. The amount of PDFF reduction is very good in my opinion within that duration. So it seems positive in the liver overall. What do you think, Michael?
Yeah, so I think at this stage of a drug's life, they're all effective and they all have no side effects. So that's where we are right now with this one. So I'm not surprised.
Michael, is that adolescent or pre-adolescent?
This is pre-adolescence. I think the 2As are mostly they all work and they have no side effects. So
Michael, go back to the NASH-TAG 2 years ago where you had the slope.
We're at the peak of expectations phase, the 2A phase.
That's right. No, I could hear you. You just couldn't hear me or see me. Then finally I decided to log in for the fourth time. But I think Mazen makes a great point about what was shown and what was not shown as a result of this particular presentation. And I think sometimes you can take away a lot from what wasn't shown. And I think Mazen was very astute in picking that up.
there are drugs in this space that work very well on weight loss. Altimmune had a press release already this year with their early phase data showing very significant weight loss. So, I mean, to me, it's a little bit like everything else we're studying. Just because one particular agent in a class may or may not show something does not mean that that's applicable to every other agent in the class. So we just have to see what works out.
So, Stephen, that was actually the comment I made while you were coming back in that I remembered. I thought Cotadutide showing some data at NASH-TAG in 2020 that was impressive about a lot of things, but not weight loss. And then Altimmune showing better data about weight loss. And me, for some reason, for one of the things we were doing, going and looking at this Hanmi drug that also shows tremendous weight loss. And to me, Mas, the thing that makes weight loss so interesting, given, Stephen, your comment about what's in the early Altimmune data, is that the Splendor study, right, suggests that bariatric surgery reverses cirrhosis. Well, what that says is that if you can find an agent that can get a 20% weight loss in a significant proportion of patients, now you're talking about doing a few really dramatic things at once. Now, yeah, Michael, that's adolescent. They're all 11 years old and they're cute as hell. I get that.
The problem here, though, I think, Roger, is that you have a second agent. These drugs, these combination drugs, they do cause potent weight loss, possibly more than just single agent GLP-1 RAs. And then you're going to pay some sort of adverse event price for the second mechanism of action. And you know that if you give glucagon, if you have a glucagonoma where you're constantly administering glucagon to yourself, you have changes in amino acid metabolism, you change your body cell mass. There are things that go along with that. So I think the secret for this group will be to learn from other studies and go slow. Don't pick your middle or highest, your most effective dose. Go a little bit easy. Go with the equivalent of the 1 milligram instead of the 3 milligrams of aldafermin. Be patient with it. Don't go with the biggest bang for your buck. And I think you're more likely to get away with weight loss that's consistent, it's tolerable. They all have GI side effects, all these drugs. I think that's probably something they should all bear in mind.
I totally agree with Michael, but there is quite a deeper story or quite a deeper meaning to what you said, Roger. 2 years ago, there was a pessimistic look or opinions about the NASH field with multiple trials that failed. Now, what we're looking at is, you just mentioned the JAMA paper, we have multiple weight loss. If you think about it, if someone wants, what's the right word, to invest correctly in the right thing, NASH is going to be resolved eventually, or rather with a weight loss drug, rather with a drug solve de novo lipogenesis. But at minimum, now we have data that bariatric surgery reverse outcomes, or weight loss, if you get there, you're not going to go to outcomes. We have drugs that can do as good as weight surgery, and these drugs are working on NASH. So logically, Michael put it the best way, we're going to get there, it's just too early. And in the next few years, it's a natural progression that this field is going to resolve, and we're on our way there. Rather than a few years ago, we're thinking like, oh my God, we don't know what's the outcomes, we don't know what's the primary endpoint and all that. We're going to get there no matter what, because we know we're going to achieve the solid outcomes. Stephen mentioned earlier, the NITs are moving in the right direction. The biopsy is going to go away, and no matter what, even the solid outcomes that everyone thought it's going to take forever, we're seeing them already. So it's going in the right direction.
Other comments, or should we go to the next paper?
Good time for the next paper, Roger.
I think so. So,
Stephen, why you have a good connection? Do you want to leverage that?
I think, you know what? I think that's a good idea. Thank you, Michael. Stephen, you're up.
The talk I wanted to go through briefly, or the presentation, was just the one I did. I think it's just worthy of a discussion from the group, and that's the vonopexor, the FXR agonist that I presented at the Late Breaker. You guys know about FXRs, right? They're key targets in NASH pathogenesis. This is a particular FXR that's a non-bile acid. It's highly selective
FXR agonist. And there's a unique thing about this one, at least leading into the work in NASH. There's actually some preclinical animal data in kidney disease. And knowing that FXR is also expressed in the kidney, the work that was done there was actually supportive of a role of this particular FXR in modulating kidney disease. So while that wasn't a primary endpoint of the study or even a secondary, it was an exploratory and something that was evaluated. So there were actually two parts to this trial. Part A, 24 patients had a run-in scenario where we looked at safety and PK/PD. What I presented at this meeting was 96 patients that were enrolled in Part B, which was treatment for 12 weeks with either placebo, 100 milligram dose, or the 200 milligram dose. And in that 200 milligram cohort, you were started at 100 milligrams for 2 weeks and then titrated upwards. Now, importantly, this was not a biopsy to get in, biopsy to get out study. This is an early phase 2A proof of concept, show me something positive study, and show me some more safety data. And so this was presumed NASH. In other words, they looked at FibroScan values greater than 8.5, PDFFs greater than 10%, AST greater than 20, and with a goal to try to get at an active NASH population with some degree of fibrosis. And I think that was successful. So if you look at the baseline characteristics, mean age is in the 50s, about 40 to 60% of patients are diabetic. The PDFFs are all around 20%. And the multi-parametric MRI CT1 scores are between 875 and 925, putting it into an active NASH population, and FibroScan values between 10 and 12. A study was enrolled in the UK, or in Europe, and in the US. The primary endpoint was change in absolute liver fat fraction at 12 weeks, and that primary endpoint in this trial was met. The 100 milligram dose had an absolute change of about 6%. The 200 milligram dose about 5.4%, and placebo 2.3%. Diving into that a little bit more, looking at relative change, we showed some waterfall plots of the three different placebo and the two different doses. And if you draw a line at the 30% relative fat content reduction, about 50% of patients in the 100 milligram arm hit that, 39% in the 200 milligram dose. So not quite as good, although some of the PDFF changes were more dramatic in the 200 milligram dose. Overall, not quite as many people hit the relative change of 30%. And it was only 13% for placebo, so this was significant. And then maybe one of the more interesting findings was the change in CT1. That was about 79 milliseconds in the 100 milligram dose and 72 in the 200 versus 10 in the placebo. So significant there. Waterfall plot showing about a third of the patients in the treated groups having an 88 millisecond change. And we know in a recent publication that is linked to at least a 2-point improvement in the NAFLD activity score. ALTs also changed, although really only significant in the 100 milligram dose arm. There were positive impacts on body weight, waist circumference, and then to the GFR issue, there was a significant improvement at time point week 12 and week 14 for both the doses of onofexor versus placebo. And just linking that to the recent New England Journal publication by Arun and colleagues, showing that up to 2/3 of patients with NASH have subnormal GFR, and with a confirmed frequent eGFR event prospectively identified over a 4-year period of time. So if we're able to improve liver disease and renal function in the same patient, I think that would be something to consider. And then linking back, we did talk a little bit about the preclinical model. This was a chronic kidney disease mouse model that looked at inducing chronic kidney disease over 5 weeks with subtotal nephrectomy and then treating for 3 weeks. And it was compared to obeticholic acid, losartan, and then vehicle. And there was a significant improvement with this particular FXR, vonopexor, versus the other agents. So as far as safety, this was characteristic of an FXR. There was pruritus. There was a rash in one particular case. There were 2 cases of elevations in ALT. One was in a biopsy-proven autoimmune hepatitis case that was thought to be non-drug related. And then the other one was an isolated ALT where the baseline went from 145 to 185. LDL bumped as well, but could be mitigated if a statin were started or the dose was titrated upward. And so ultimately the primary endpoint was met in the trial. There were improvements also in CT1 and other fibroinflammatory markers. And then you had this novel finding of GFR improvement, which when I've looked back, I haven't been able to link that to other FXRs. The weight change, we have seen that was shown in the Flint trial as well, and perhaps others I can't think of right off the top of my head, and maybe Michael or Mason are aware of other FXRs where weight loss has been shown as well. But I do think in this early phase proof of concept trial, this dual benefit of liver benefit and maybe some kidney parameter improvement in GFR do warrant further investigation in this particular subset of patients. I'll stop there and see what you guys think.
I agree with everything you said, of course, Stephen. I was very encouraged. I think it's a mature approach to FXR. I mean, all FXRs will make people itch. At least some people will itch with it, and there'll be some lipid changes. But I thought the efficacy, the PDFF data were good. My only concern with the PDFF data, Stephen, with that, historically, that's not been a great predictor in FXRs. So I'm not quite sure what to make of that, but everything else I think was reassuring.
Stephen, you said there was a weight loss.
Yeah, there was weight loss as well as decrease in waist circumference.
I mean, that was seen in the tropifexor data that they lost weight as well, but the efficacy definitely is better. So, I mean, I think it's a good data. It's definitely in the right direction. I think the design is definitely smart. I'm glad that they have the CT1. You have PDFF as well as CT1. You have ALT reduction. So you have multiple good endpoints going in their favor. I don't mean to make it expensive for companies. I would love to see MREs in the future in these trials, but we're just going to bankrupt companies. But I think between PDFF and CT1s and ALT, this is very encouraging for them.
I'd like to see stool fat. My worry is that these drugs are pretty good at affecting bile salt production. So I wonder if you give a potent FXR like this clearly is, do you end up with some malabsorption? And maybe that's part. Are you giving orlistat? Is it an orlistat-like function that you get with these drugs over time?
Well, orlistat works if you.
It does. I agree.
But I think the unique thing about this presentation and about vonopexor was the heretofore unseen GFR positive impact, and I wonder why that is. I mean, if there are FXR receptors in the kidney, how come we didn't see it with any of the others? Is it because I don't think it's serendipity. I don't think it's just this unique patient population.
It may be tied to the weight loss, Stephen. Okay, so it's not GFR that they measured, it's eGFR. And eGFR will be affected by body cell mass. So let's just say you are losing weight. Everyone who loses weight loses body cell mass and creatinine. So it may be that the GFR changes were a simple reflection of that.
That's a fantastic point, Michael. Then that may in fact be true, because the weight loss was not, it wasn't exactly minimal. I mean, I'm just looking back. You're talking with the 100 milligram dose at week 12, you're talking 2 kilos.
Yeah.
2 kilos of weight, 1.5 to 2 kilos at 12 weeks. And
you see the same thing with GLP-1s.
Yeah, that's a great point.
Yeah. I thought I was going to ask.
Were those diabetics? I mean, I'm sure they were diabetics, a lot of them. I just wonder if the improvement in the GFR That's
it wasn't breaking.
very
It wasn't
soon.
broken down. Post hoc analysis on this wasn't done, Mason. About 40%, about 40 to 60% of patients were diabetic, and those were all well controlled. You had mean HbA1cs of roughly 6.5.
Yeah, I mean, Michael's point is very sharp, and that's a very sharp first observation. I'll break the GFRs if they improved on the diabetic versus non, and if you had urine on them, if they have proteinuria or non, stuff like that, which will go with Michael's observation of the weight improved.
Now, there was some additional data, Michael, with alpha-2 macroglobulin, and there was an A2M decrease, which correlated with EGFR improvement. And we know that A2M correlates with deteriorating renal function in diabetics, but not with glycemic control.
I mean, this is very important because I don't want to take a lot of time because we have a lot of abstracts, but right now in the clinical trials of NASH, just want to remind ourselves that there are groups that we exclude. A1C more than 9.5, renal insufficiency, and a lot of these patients, we're going to deal with them later on. And it's good to know that this drug kidney function, so that goes in its favor.
Yeah, and I just looked again. So it wasn't just tropifexor, it was also Medicrin that had weight loss with their FXR.
Did they track GFRs or EGFRs as well, Stephen, or is that something that was only tracked here?
You know, I mean, they did GFR. That was followed in all of these trials, but it wasn't something that was reported. So I'm sure they have it, and if they had it and there was a change, we would have seen it. It certainly wasn't in the Regenerate. This wasn't something that was highlighted. And it wasn't in Flint. Weight loss was apparent in Ocaliva as well as tropifexor and Medicrin. But there's no comment about GFR improving. Now, this is EGFR, as Michael pointed out.
Yeah, and you may want to go back to, you're one of the lead investigators for the OCA studies and see if among those patients who did lose weight, was there at least a trend for GFR changes?
Yeah, I agree. But it is nice to see that a biomarker, like A2M is also moving in the right direction.
If you think of it, I mean, one of the breakthroughs early on for the SGLT2s was when people realized how many organ systems they could be affected, right? And
yeah, you if you're going to use an FXR long term, it's going to be in combination. We used to have this mindset when in the early days, maybe 4 or 5 years ago, that the FXRs would be backbone treatment for this disease. And I don't think any of us think that FXRs are going to be the backbone therapy for the treatment of NASH. If anything, they'll be additive in a reduced dose model to get some positive synergistic impact with minimizing the AE profile. So if you can get positive impacts on kidney disease as well, that would be another feather in the cap of using a low dose FXR in combination.
Well, so Stephen, thank you for that, and congratulations for having your internet let you get through that talk nicely. Thanks for that. Jeff, Louise, one of you want to go next?
I'm going to reserve my time, Roger, and pass to Louise. It's been quite a bit since she actually had her little bit of chocolate, and she's been alarmingly still on the video frame here. I fear her falling out of her at her time frame. So, Louise, I'm going to pass to you, and I'll follow up.
What I know that you don't, Jeff, is that she spent all her random joy on England beating San Marino 10-0 today.
It was a pleasure to watch, I have to say. It was just as the sessions were moving on. But I'm going to do a couple quite quickly, one of which Stephen was a co-author on, I believe, which was the Jamie Bosch presentation. So do step in here, Stephen, if I get this wrong. And it was the impact of modest weight reduction. So going back to weight, there's been quite a bit that I've listened to where we talk about very small weight differences make a change. And I see that in clinical practice, that keeping people encouraged with just small weight making a change. So this interested me basically for that. And it was modest impact of modest weight reduction of serum markers, liver histology, and disease progression in patients with advanced fibrosis due to non-alcoholic steatohepatitis. Now, it was Jamie Bosch. And basically, what they were looking for was weight reduction post-bariatric surgery and pharmacology has demonstrated that you can get more than a 7% weight loss in NASH resolution for patients, rather than like the study I looked at last night, and over 10% weight loss is associated with fibrosis regression. So what they did was take the simtuzumab 105 and 106 studies and the STELLAR 3 and 4 studies, and what they did, obviously they were terminated due to lack of efficacy. So they pooled the groups for the analysis, and what they wanted to do was determine the frequency of moderate, more than 5% weight loss in NASH clinical trials, to evaluate associations between the weight loss and changes in the clinical histological parameters and disease progression in patients with bridging fibrosis F3 and compensated cirrhosis F4 with NASH. So basically the study endpoints with the histology, what they did was also include ELF, liver stiffness, biochemistry, HbA1c, other measures, and progression to cirrhosis from the F3 group, and any events, hepatic decompensation, ascites portal, hypertension-related hemorrhages, for example, and encephalopathy, increase in MELD, and death. Body weight measured every 12 weeks in the STELLAR and the SIM trials, respectively. So their statistical analysis between the weight and change parameters evaluated during the Fisher's Exact and Mann-Whitney tests. And what they did was look at the associations between weight loss with progression to cirrhosis in the F3 patients, adjudicated with clinical events. So week 48, 247 patients finished with 12% had more than a 5% weight loss, median 6.9 kilos. Most of the baseline characteristics in those were the same. Patients with less than 5% versus patients with more % weight loss had similar features at baseline. Among the F4 patients with more than 5% weight loss at week 48 had a higher median transient elastography score at baseline than those with less than 5% weight loss. But similar observations when patients stratified by less than 10% and more than 10% weight losses. So when they looked at changes in clinical parameters according to more than 5% weight loss, patients with that more than 5% weight loss at 48 weeks had a greater improvements in their biochemistry, non-invasive therapies, HbA1c, but changes in bilirubin MELD and hepatoportal vein gradient, pressure gradient didn't differ. Histological responses according to weight loss at 48 weeks, again in the 5% group, weight loss were more likely to achieve NASH resolution and improvement in NASH parameters, but fibrosis improvement was similar between the groups. Data in F3 and F4 patients were consistent. Association between more than 5% body weight loss and progression to cirrhosis. Patients with the F3 fibrosis progression to cirrhosis was not significantly associated with more than 5% weight loss, 13.9% against 17.4% with less than 5% weight loss. The association in the groups between 5% and liver-related events in patients with cirrhosis with greater than 5% weight loss, they were more likely to have a liver-related event, 11 versus 4%. So basically the conclusions of the study were those with greater than 5% weight loss over 48 weeks is uncommon, 12% in clinical trials for patients with advanced fibrosis due to NASH. The moderate weight loss led to improvements in disease activity, non-invasive measurements, HbA1c, but was not significantly associated with the improvements in fibrosis assessed histologically or hepatic portal vein pressure gradients, particularly in the F4 groups over 48 weeks. And modest weight loss in the patients with cirrhosis was associated or is associated with an increased risk of liver-related clinical events, which they felt likely reflected the weight loss driven by disease progression. And in the discussion post the presentation, it was suggested, or he felt that was probably due to the muscle loss and sarcopenia driving the liver-related events, of which the biggest events were ascites and esophageal variceal bleeds. So I don't know whether that's the correct summation, Stephen, but I thought that was quite interesting.
You could have given the talk, Louise. You did marvelous.
Pressure on.
You should audition for that. In fact, Michael, we need to talk to Maru about getting her on more AASLD roles to, speak.
I agree. I completely
That's
agree.
the English accent. Mary Poppins comes to town.
You just have to give her more chocolate, though.
Yeah, and less spoonfuls of sugar if you're going to be Mary Poppins.
Well, I did that on LinkedIn not so long ago following that. But the one that I'm going to follow up with that slightly, just to present the second one quite quickly, was the one that I alluded to at the beginning, which was the presentation.
Can I make a quick comment on that presentation? Mm-hmm. I'm a big fan of Professor Bush, and I think everyone in the hepatology field. I think it was fascinating, and he did a lot of work on portal hypertension, and he answered the questions eloquently. And one of the questions he emphasized on that he said if you lose the weight correctly, he showed previously in general weight loss in the correct way lead to decreased portal hypertension. But one thing crossed my mind, and I hope that I don't have to bite my tongue and regret that I'm making that comment, is if you are losing weight by more than 5%, but you're still getting more events, to me, if you're getting more events, you're supposed to get more portal hypertension in general. That means your gradient should go up, which you did not see. Unless, I don't know how they define the events. Is it increase in MELD score? It was not clear to me, but in general, if you get more events, that means increase in portal hypertension.
Amazing, you bring up a good point. One of the challenges with this study, again, remember you're enrolling advanced liver disease patients, and as you develop sarcopenia, is that sarcopenia the reason for the weight loss? And as a result of that, we're actually seeing a progression in those patients that are with liver disease and portal hypertension that may or may not be measured appropriately with the techniques that we used. So, I mean, that was one of the debatable topics was some of this weight loss sarcopenia.
Stephen raises an interesting point. There's a UK study like NHANES, but much more broad and sophisticated in some ways, 40,000 people. And in that study, sarcopenia is more predictive of mortality than even having breast cancer or lung cancer. So the sarcopenia in and of itself may be a better biomarker for events than HVPG mass. I'm just hypothesizing that.
That's correct. And there have been recent talks about measuring portal pressures in the NASH patients and its accuracy and variabilities because of weight and all that. And I think Professor Garcia-Tsao wrote an editorial in Hepatology about that, but we will leave it for another time and another talk.
Well, can I just hypothesize? I listened to yours and Manal's session with Madrigal when you were doing the Maestro studies, and I think one of the measurements there was liver mass. If you lose weight, do you lose liver mass? If you lose liver mass, does that affect your portal pressure gradient? So therefore, maybe it doesn't go up if you lose the mass.
That's a great comment, and I think you summarized one of the take-home messages of not only that study, but of the High Tide 1801 trial, where, essentially we looked in a univariate and multivariate model what predicted change in liver fat content. And what we found out in a multivariate regression model was that weight loss, change in HbA1c, and change in ALT all were associated with change in PDFF, but only accounted for 33% of the PDFF change. And knowing what we know from Mason's presentation and now additional data coming through from others, is that spleen volume decreases with weight loss, spleen volume decreases with PDFF decrease, liver volume shrink as liver fat content goes down. And one of these hypotheses is that you're improving blood flow, you're improving hemodynamic circulation, and that might actually lead to further reduction in liver fat content. That can't be explained by any one of those variables I just mentioned. So it's one of these findings that we're identifying now that probably deserves further evaluation, where we're able to look at it. And the nice thing about some of these trials is we can go back and look at that data, because spleen volumes have been obtained but not really evaluated in many of these phase 2 and even one of the phase 3 trials.
So do we have more on that, Louise? I was going to give you my slot to talk about the GP paper because it was a paper I wanted to hear talked about. So if you want to cover that quickly, and then we'll go to Jeff and to Michael.
I can do that, or I can do that when we next record, because we're doing another one. But I will just summarize it in that context. So it was the Fibrosis 4 Index, severe liver disease, put my glasses on for that one, Index and Severe Liver Disease Outcomes in Primary Care, Stratified Cox Analysis. It was Andrew Schreiner, and it was done in the Parallel 29 NAFLD and NASH Management Outcomes and Clinic, and well worth a repeat for anybody who hasn't seen it. And I think the main bit for me was what they did was basically do a retrospective cohort study of primary care based on electronic health records from 2007 to 2018. Study population were adult patients, internal medicine, and patient-centered medical home. And they had a visit on at least one occasion during the study period. So the inclusion criteria were patients who were required to have at least one set of aspartate and alanine aminotransferases, so AST, ALT values, both less than 500 international units per mil. During the study period, the platelet count at the time of or within 2 months preceding the AST-ALT results. The first occurrence of these inputs were used for the FIB4 calculation. The exclusion criteria were that they excluded all patients with known chronic and severe liver disease prior to the FIB4. And ultimately, what they did with the methods was they took the FIB4, looked at its cutoffs, and basically the same cutoffs that have just been advised by the AGA in the NAFLD risk stratification clinical pathway. They stratified them and they analysed them, ANOVAs, chi-square tests, Kaplan-Meiers, and they did various sets of investigation. But I think ultimately what it was the results. So they included a total of 20,556 patients. Baseline characteristics were okay. 2.3% were diagnosed with NAFLD, 8.2% with other chronic liver diseases, and 0.5% with NAFLD and other chronic liver diseases. But I think when we looked at the FIB4 risk category and the characteristics, there were quite a number of patients in the high categories there. So their results overall, and I am skimming through this because I haven't prepped it probably to do tonight, but in the severe liver outcomes occurred in 2.2% of patients with low risk FIB4s, 4.2% of patients with intermediate risk FIB4s, and 20.8% of patients with a high risk FIB4. So these were patients that hadn't been ever picked up, had just floated through the system, and what it was a retrospective result because GPs don't really engage and haven't done with FIB4, and that's what he was saying. Although it's very familiar to the liver world, it isn't something that they talk about in primary care. But 49%, so 411 patients out of 837 with a severe liver outcome had no chronic liver diagnosis beforehand. That is absolutely frightening. They did accept limitations that the FIB4 was not designed for use as a general population study. In all of these results must be interpreted with caution. Our outcomes of interest was the composite ICD-10, 9 and 10 codes. which are not reliable as liver biopsies, we know. Death they couldn't use as an outcome. But ultimately, if you look at Zabier-Younossi's data from yesterday and the rise of fatty liver and the costs, FIB4, if you retrospectively look at patient volumes like that, just reveals a shocking state of the amount of liver events patients are having, even with a low FIB4 risk. So that was the wow moment from that. And there were obviously a lot of questions discussed afterwards. And one of the questions was, did he recommend automated FIB4 for primary care? To which his answer was quite correctly no. I felt that was the right answer. I think we use it to get the liver population of people we suspect and our lowest hanging fruit. But as a general population screen, it's probably not effective on the numbers that they produce there. But it is well worth a watch. And it was oh my God.
Which abstract was that again, please?
It was the Parallel 29 session, and the abstract was the Fibrosis 4 Index, Severe Liver Disease Outcomes in Primary Care, a Stratified Cox Analysis.
So, Luis, we had data was published in JHAB from Hextrom et al. Showing also that there were quite events in the low and intermediate FIB4 category that had clinical events. So that's now US data confirming that prognostic data, which put all of us on our toes. And I do agree with his answer that it should not auto-populate it for the general population. It should probably auto-populate it for the high-risk population, because you just don't want to make the primary care dizzy with auto-population for everyone for fatty liver. So I just wanted to throw that other publication out there, because that's not the first time we see this phenomena.
The figures are just concerning, even with the events of a low FIB4 score, the amount of liver outcomes on that. So it was surprising. I wasn't expecting it. I was just listening to it, and it got, wow.
So why don't we go to the next paper? We'll have time for one, maybe two, or Michael, you want to do one, Jeff want to do one, and then we'll be done.
I can do one.
Guys, I'm going to have to jump off. It's my wife's birthday, so I gotta jump and actually do a birthday.
Happy birthday, Renee, and thank you for joining us.
I'll let y'all finish up.
Enjoy your dinner. And Mazda says don't do a 4-hour omakase.
Okay. Yeah, no doubt. Thanks, guys.
Thanks, Stephen.
Happy Thursday to Renee.
So the abstract I'm going to talk about goes back to 2018. And there was that paper in New England Journal. First name author was really not as important as fact. It was a study that was entirely conducted by Regeneron in collaboration with Geisinger. And they reported that in a study of, I think, 50,000 people, that HSD 17, B13, or hydroxysteroid dehydrogenase 17, was a potent predictor. A loss of function variant was a potent predictor of not getting cirrhosis for a host of chronic liver diseases. And it was up to 70% predictivity based on this loss of function variant. And it got everyone's attention because this company has a track record of taking these kind of observations into phase 3 and approved therapeutic agents, PCSK9, for example. So it was a very interesting observation. You wind forward to this liver meeting, and we had several interesting pieces of data that we may have begun our first glimpse of the NASH vaccine. It's not impossible. So the first study that caught my attention was Heather Zhu from Inopharm. And this company has a molecule that inhibits the catalyzed oxidation that HSD17 performs. And they use the liver on a chip platform to show that the things that we care about, collagen production, smooth muscle, ASMA, anti-smooth muscle actin is downregulated. So nice in vitro data. And then we had a study by Arrowhead Pharma. And I forget the first author in here. I have it open here. Let me see. And this, I think it was the most intriguing study at AASLD, and it was only as a poster. It was a late-breaking poster. For me, it would have been late-breaking oral number one. And this study took an RNA inhibitor, a small RNA inhibitor that was injected on day one. And then again, I think it was day 20 or day 28, something like that, day 29. So at day one and 4 weeks later, subcutaneous injection at 3 different doses, at 8 patients per arm. And they got patients to have biopsies at baseline and then again at 10 weeks. An amazing feat. How you persuade I have trouble persuading patients to get any biopsies. To get it twice in 10 weeks is extraordinary in and of itself. But they did it. And so they were able to measure the production of this protein, because the way RNA inhibitors work is they should shut off or slow down the production of your protein of interest. Remember, this is a loss of function variant that's protective. So they did it in a logical way. And they showed up to 90% reduction in their week 10 knockdown of HSD17B13. And they, even with a small number of patients, I think 6 per arm, they had 30+ % declines in ALT. They showed changes in liver stiffness in about a third of patients, and they had changes in liver fat. So it behaved exactly as you would hope. And this is getting our own cells to really treat. So this is for me, this was a very exciting demonstration. And it's a small study, make no mistake about that. But because of the mechanism and this pathway of taking something that we know makes sense genetically, because it's observed in these tens of thousands of patients GWAS studies, then you translate that to this kind of clinical trial. And there are others out there. There's Inopharm, there's Alnilim has a molecule as well. And they're taking different approaches. Some are inhibitors of HSD17B13. Others are the knockdown through RNAi, et cetera. So we have multiple approaches getting at the same thing. And I think the first glimpse at could it work? The answer is an overwhelming it could. I wouldn't even read more to it than that. We don't know about the AEs. It's too small to tell. But for me, this was a very exciting proof of concept.
I share your excitement, and I actually missed that. How many patients, Michael?
Just 18.
And how much improvement we're talking about in terms of PDFF and MRE? I know you might not have it.
So PDFF, they weren't sure. I wasn't sure. I've been following this story as closely as I can. I wasn't sure what to expect because in mice, it really doesn't have a phenotype. So it's been hard to know what you would get. But it is a super regulator of lipid droplets, and droplet size does seem to decrease with this. And the drop in liver fat on average, let me give me a second here, Mazen. The absolute decline was nearly 8%.
That's a good drop for such a period of time.
Yeah, exactly. Yeah. And I don't think they were really hanging their hats on that. And then FibroScan, nobody expects that to fall, but in a third of patients, that improved as well. And the decline in ALT was about 40% in the 100 and 200 milligram dose, and just 2 doses. So you're sort of, it's an injectable, longer-acting approach in a sub-Q injection. So, and we also have these other molecules. One may be oral. I'm not sure. They don't really declare how that will be given. It's a small biologic. It's a small molecule. So I'm not sure how that will work. Whether you can have to inject that or can take it by mouth.
Well, so first of all, thank you for sharing that. That has skipped me entirely as well. Do you have what is the poster number on it? It's going to be LP something, right?
Yes, I'm going to tell you. It is. I put it in my email to you, Roger.
Okay, I'll find it. Yeah, okay, fine. I can find it. Actually, I wanted to read it on podcast, but I will find it so I can read it on podcast while Jeff is going ahead and talking. Okay, that's great. Any other questions for Michael on that before Jeff goes on? Okay, Jeff, it's yours.
All right. Thank you, guys. I am going to bring the lifestyle management perspective into this. As the session that Roger and I talked about, my covering for the show was Kathleen Corey talking about lifestyle management of NAFLD with obesity. And there are 3 quick studies that she went over that I'll be brief in reviewing here with a little bit of comment on the side as well. The first was with a study of just under 300 adults with biopsy-proven NAFLD, and that their intervention was to basically attempt to get weight loss for them. And so they intervened by using a dietitian at 8, 16, and 24 weeks, and then a 2-hour group session at 32, 40, and 48 weeks. Now, lifestyle, according to them in this, is basically based on a hypocaloric diet and aerobic exercise. And I think that actually points to a problem that we have in the field of defining lifestyle too narrowly that we can come back to after this, but they are focused on those aspects of that. In the end, and there'll be a theme that runs throughout all of these, 70% of their cohort failed to lose at least 5% of their total body weight. But their results, which I don't think would surprise anybody, is that when patients were able to achieve 10% of weight loss, over 70% of them achieve some sort of NAFLD resolution in that regard. And so we know, as we've talked about, even referred to earlier in the show tonight, that 10% is probably the sweet spot for here, but even with 7%, there is an impact with that as well, and a conversation probably around 5, but that 7 is good, 10% is going to be the sweet spot for that. I think it's important to also emphasize, and this came up in the question and answer for that it was a 1-year study, and that after 1 year, only 30% of the participants had achieved 5% of total body weight loss. And so in general, not a lot of good outcome on that, and it only kind of really reinforces what we know, which is that the goal is around 7 to 10% of weight loss. And their recommendation actually was that if the weight loss failed, and that there were indications for weight loss surgery, then that should be considered in this. Now, the second study that she pointed out, and this was pretty revelatory for me because I haven't heard it spoken of in positive tones very much, but was a 12-week study on the impact of intermittent fasting. And for them, intermittent fasting was basically 5 days of a normal diet plus 2 days essentially of 500 calories, which is a very different definition of intermittent fasting that I'm familiar with some of the athletes and the friends that I have that have done that from time to time. So intermittent fasting, the results found that intermittent fasting plus a low-carb, high-fat diet resulted in decreased fat, which is a positive, but it increased their LDL, which is not great. However, if they went to an intermittent fast and just received basically a standard of care, then they found that that was the diet that was best tolerated, that it reduced the LDL, and that there was a reduction in liver stiffness as well. Now, for this, they also define, there's a physical activity component for it, which they defined as walking 90 minutes a week, building to around 200 minutes a week. And if you've ever done any, running or walking or training in any sort of way, for a 12-week study, that's a pretty fast build to be able to do. That's a pretty intense build to do over that quick amount of time. They did find their recommendations, and it kind of came back to the earlier clinical practice updates that came from the AGA, which was, that the Mediterranean diet was going to be preferred in this, and that it was seen to be able to reduce liver fat, even potentially without weight loss also. Finally, let me talk about the last of the studies that she reviewed, or the abstracts that she reviewed, which was a meta-analysis of around 20 studies or so. And taking a look specifically, she says exercise. I tend to use physical activity as a synonym for that, so forgive me if I trip myself up on that, but that they found in the meta-analysis of 20 studies that exercise, even in the absence of weight loss, did tend to help with liver stiffness. Now, they did also find that exercise with diet actually improved NAFLD resolution. And when they defined exercise, they found no difference between aerobic exercise and resistance training. And again, their aerobic was defined as 150 to 300 minutes of exercise a week, or for kind of moderate exercise, eventually building up to vigorous exercise of 75 to 150 minutes a week. Now, I think what is interesting about this is not the results that it helped or exercise with diet improved NASH. I think that's something that we have seen and that we tend to kind of believe. But when speaking to the participants afterwards, this was what was noticeable to me, that number one, 75% of the participants did not achieve 150 minutes of physical activity a week. Then, if you drill into that, she found that 41% performed 0 physical activity a week. Now, what this points to is when they would ask them, so what's up with that? You're enrolled in this. Why didn't you do your thing? And 47% said that they had a lack of education or resources when it came to what to do. 44% pointed to physical discomfort, that it hurt, or that there was some sort of pain afterwards of what they had done. 32% pointed to time, which is like something obviously we can all point to. 21% spoke to cost, and 24% spoke to lack of access. Now, this really points to, when we talked about our word that we came to this with, the word that came out of this session for me simply was barriers. That individuals that are going through lifestyle modification, attempting to do management for their weight loss, even in ways that may not impact weight loss, but could positively impact things such as liver stiffness, just simply did not know how to address the barriers in their lives. And I think this points to a really critical piece of conversation that clinicians need to either have or be able to refer to in terms of talking about lifestyle management. That simply telling, a patient to, well, you need to get some exercise, here's how many minutes, or you need to, watch your diet, here's, a ratio of what to do and not do, is not that far from just telling an alcoholic don't drink or spend less time in the bar. I think that we need to have a little bit more specificity around lifestyle management based on these recommendations, and need to be able to more proactively address these barriers. What does physical discomfort mean? Does that mean they were sore? Does that mean that they did too much too early? Does it mean that they weren't paced? Perhaps they are experiencing joint issues that are an issue. And I want to also, kind of in conclusion here, point that when my experience of people talking in the field, talking about lifestyle management, generally leaves two very vital components of this out. And that is mental health, being able to be positive, being able to address whatever issues around mental health are needed to be able to encourage them the behavior that can then help with addressing some of these barriers. And the second one, which I really haven't found addressed as much, certainly not as much as nutrition and physical activity, and I know it pops up in the conversations from time to time, but is sleep. If I were trying to address and do any of these things, but if I weren't sleeping for, say, sleep apnea reasons, then that would impact my ability to be able to do these sort of things. We do know that exercise rates are low among adults with NAFLD to begin with, and so we have to address why they're low to begin with, and then be able to kind of take them through. And this is really fascinating to me because it speaks not just to the motivation of the patient, and yes, I do think, to kind of pull this through, what Maz had said earlier is absolutely patients would do injectables, but what you're telling me here is that they're not going to go for a walk. And so we have to figure ways to be able to open that conversation, to be able to either have it better as clinicians, to be able to give referrals to people that can help encourage that, which would mean probably also looking at our insurance and reimbursement system. So personal trainers, exercise facilitators can then be coded in such a way that they can be referred to in much of the same way that we fight that fight for dietitians as well. And I'm sure, when we talk about barriers and lack of access and stuff, there's going to be a socioeconomic aspect of this as well in terms of the population health, that people just, in certain populations that are going to be more high risk don't feel like they've got access. And frankly, they just may have the inertia of the fights in their lives going against them for this.
First of all, thanks. That's really great, and I think it's a helpful window, and it's why I wanted to be sure that you are someone else who was locked firmly in the patient advocate camp as compared to Louise, who has some space there, but also some space in the liver wellness advocate camp, was on this, because I think that's critical. One of my questions is this. People go to doctors for medicine. That's why they take needles. If people want to get healthier via workout, they don't go to their doctor, they don't go to their dietitian, they go somewhere else. So I guess what I'm saying, Jeff, is by definition, you're dealing with a less motivated audience. And one of the questions may be, how do you get them to either change the way they look at the transaction or go to a different place, taking ownership that they have to own that? Because the rest of it is, if you just take a drug, you're not owning it. All you got to do is adhere to therapy, right? If you're talking about 200 minutes of exercise a week, that's a half hour a day. That's work. That takes real ownership.
It does. I don't think that 200 minutes have to be all at the same time, though. I mean, we very quickly get into systemic issues with access, with someone taking the stairs versus taking the lift or the elevator in that way, that those things can add up over the course of the day, and you can quickly get the 30 minutes in that way. And in terms of, people that want to get healthy, self-selected to get healthy, as opposed to the population we're dealing with of NAFLD with obesity, what I would say is that the clinician in this instance is the gatekeeper. I mean, he's the director. We often talk about patients needing a quarterback by which they can then direct, you go here, you go there, then come back here for the game plan. And we can kind of have a home base that I know I'm mixing my metaphors, but a quarterback that they can come back to that will help guide them on the plays as they continue to move down the field. Yes, I agree. They go to the doctor in order to get healed, if you will, not necessarily to get healthy or to get fit, as you said. But I think there's an important role there and a discussion that needs to happen within the field about how they can better have that conversation and have it translated in a way that patients will be more motivated. We often speak of these sort of smoking gun moments for patients of, I found out I had cancer and then suddenly that got me to stop smoking. I found out that I had, high cholesterol. That got me moving another way. And it doesn't seem like we've quite found what that magic phrase, that magic moment, that magic motivation is for patients with fatty liver disease or NASH.
I'm just going to jump in there slightly. It's also about the language. There was a sideline in the chat about not using the term exercise. Exercise means quite vigorous to most people. And I've had consultants say, but they need to get their heart rate up to 135. The reply to that is they just need to start walking. We've got to set things that are achievable. Most people have a kitchen. You can bend up and down in your kitchen. It's about movement. Increased movement increases calories. If you stand at a desk or you get up every 45 minutes, there's evidence that it reduces your cardiovascular risk. It takes an awful lot of calories to stand up. The more we do that, and we just look at simple things around the home, 2 cans of beans in your hand or something like that, make it understandable. It can make a difference. Go for the quick wins. Yes, by all means, catch the lift up, don't use the stairs, but walk down. That's calorie burn, and it's the easy way to do it. So there are little things that we can put into people's schedules that are movement increases that can allow us to just start tipping the balance in their favour. And if we tip that balance, we can get a momentum in a lot of people. And it's little things, particularly exercise frightens the boots out. That word frightens the boots out of most people. So just changing the language slightly does work.
So, Louise, the most interesting thing you did was not just to change the language, but also to completely dequantify it, right? no one's going to track how much time they spend walking down a flight of stairs. Oh, good, that took me 45 seconds. I have 29:15 I have to do today. Basically, it's a decision that you don't want people watching a clock on that, but that you want to figure out how they can how they can engineer their lives to get there without feeling like it's something specifically they're doing, I think.
Yeah, absolutely. Why do we all want to get into a lift when we've got COVID? We've got a thing. Go down the lift stairwell. If you want to go up. But actually take the easy wins and just in your kitchen, reach for the cupboard every now and again. Bend down more. Just use what you've got around you. You don't need to go to a gym. You don't need to do these things. And I think people get scared. Walking is a free exercise, but actually just start with simple wins.
Roger, as you know, I can talk about this until I'm very, very tired, and until everyone else is way more tired than I am of listening to me speak about it. Let me kind of end the analysis here with a little bit of a throw out of a challenge. We know that we deal, especially with lower socioeconomic classes, that there are a lot of systemic challenges that they have to deal with, especially in terms of barriers, lack of access, unsafe neighborhoods. We speak about it often when we speak about nutrition, about the lack of, we talk about food deserts. I tend to think more about nutrition deserts that we have that are actually a little more widely available there, or widely unavailable, as nutrition is hard to come by. I would throw out a challenge to the field, to the providers, to the industry, to anybody that's listening to this, and ask, are you modeling the behavior that you need your patients and your clients to adhere to? We know that there are systemic issues with this, and so in your office, in your daily practice, in your employment, where you have that ability to control, are you modeling the behavior that you need to as well? Do you take the stairs? Do you allow for breaks? Do you do walking meetings? Do you do these things as a matter of rote in order to be able to encourage the healthy behavior? One of the things that a patient will call BS on really quick is if they're being told something and see the doctors and the staff and the industry not doing it.
Mm-hmm. So I think that's a great point on which to close, because we're kind of at the end of everybody's time. So I want to do a last. And Jeff, I'm one of the people who walks up stairwells in airports and realizes that nobody within 25 years of my age is walking with me. So I get exactly what you're talking about. But just last question, okay? For each of you, from the place where you touch the fatty liver community, what's the one thing you would like people in that place to take out of this meeting?
To remain hopeful despite some really significant disappointments and setbacks, some exiting of the space by important companies. I think there's tremendous hope, and I don't doubt at all that we'll have, for those people who are not able to succeed with what Jeff and Louise just referenced, which, as you both pointed out, is most people cannot do it. But I think we will have a therapeutic strategy at some point in the medium term.
Good. Louise, why don't you go next, because it's late, really late for you.
I was just going to say that there's more and more evidence coming out for certain individuals that very little weight loss can actually change internal liver health quite rapidly. And I think it is about targeting those people, but it is about making those small changes to start with. Don't make the big ones, just make the small ones. Because we don't want, it's a marathon, not a sprint, as everybody says regularly. A small change makes a difference. You may not think it, but it does. And I think there's more and more evidence come out at this conference now, and more about individual cells and sort of that person-centric treatments that we'll probably cover in the next few weeks on that.
Mm-hmm. Okay. Marcel?
I think 2021 is a good year. We have GLP-1 data from SEMA that showed significant improvement in the disease. We have LANI in the New England Journal. We have the JAMA data on bariatric surgery. NIT had made progress. We have society guidelines in this meeting. We're moving beyond the biopsy. Yes, as Michael said, we have negative data, and that's the nature of the beast. So, but we have way more positive things. And we also announced in this meeting when the resmetirom data will be read out. So we're on the right track. So just keep positive. The glass is half full.
Yeah, I agree with you. What I felt this year more than anything else is the overall energy levels going way up, right? Lots of little pieces of data contributing to a much broader dynamic and a better sense of interconnectedness and people starting to admit that they want to be passionate about this. Again, when OCA happened in 2019, it was like nobody wanted to admit they had hope for a while, right? Oh my gosh, they just squashed us. And then it was a big moment for me 6 months later. One of the patient advocates, not Donna and not Jeff, but one of the others, on this podcast made a comment that maybe it wasn't a bad thing for us that OCA never got approved because we would have relied on it and it wasn't really the drug we needed anyway, and we need to be more resourceful for ourselves. I've watched the entire research community do a similar thing with the conversations you guys are having tonight. So my takeaway is that there was more positivity in this meeting than I felt. And it's hard to feel positivity in a virtual meeting because you don't get any of those energy connections, right? So I think this was really positive. I felt really, really good about it. With that, let me thank you guys for being so patient. Louise, we're not going to make you do 1:30 in the morning anytime in the near future.
Yay.
Well, actually, we don't make you. You choose to do it, and that's very sweet of you and very, very good of you. Jeff, thank you so much. We'll have you back on more often. I think it's been great having you, and as we start to get more towards these issues of patients and behavior and all that, I think you bring a background that no one else who we have on does. And Mazen, always, I don't remember when you're back next, but it's sometime in the next couple of weeks, or it should be if it isn't. I'll talk to you tomorrow. Okay, everybody, no business section tonight, so this is it. Just stay safe, surf on. We'll be posting within a couple of days after this, the wrap-up session from the meeting. Everybody, have a nice evening, and bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.